Hello, everyone. We're going to give people a couple more minutes to sign on, so hang tight. Get started in just a few minutes. Hi, everyone. For those of you who just signed on, we're just giving people a few minutes to get onto the webinar. We will start in about 1 minute. Good afternoon, everyone. Just a reminder, we'll get started in a few more minutes. Thanks for joining us. All right, guys, we're going to go ahead and get started. Welcome to our webinar today, everyone. My name is Jess Eyre, and I'm the Regional Resource Director in Maryland for Caron Treatment Centers. Today, we have the presentation, Adverse Childhood Experiences and Substance Use Disorders, Understanding the Relationship Between ACEs and SUDs, and Establishing a Treatment Approach. As a reminder, we will be conducting this webinar we will be conducting this in webinar format. So all of your microphones will be muted and we're not able to see you. We're not able to hear you either. So if you have any questions, please use the Q&A feature at the bottom of your screen. We will answer those questions at the end. And depending on the volume of questions, if we don't get to everybody's, then you will hear directly from your regional resource director at Caron, who will answer those questions at the end or via email later. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting and providing these credits through co-sponsorship with the APA. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. You will also need to be on the webinar for at least 50 minutes to the full hour to receive those credits. Once you have completed the presentation, a link will be emailed to you directly from cego.com. You will complete the evaluation in that email, and then you will have immediate access to your certificate of completion. Today, I am excited and proud to introduce our 3 presenters, Dr. Margaret King, Cara Falco, and Brianna Hurwitz. Dr. King is the Supervisor of Trauma Services at Caron, Pennsylvania. She is a licensed psychologist in both Pennsylvania and Delaware. Joining Caron in 2017 as a staff psychologist working with men, women, and transgender individuals across the lifespan, Dr. King has a focus on teen and young adults. She is trained in EMDR, trauma-focused cognitive behavioral therapy, internal family systems, seeking safety, and cognitive processing therapy. She has previously worked as a psychologist in the Delaware and Pennsylvania state prisons. Dr. King presents at local, state, and regional conferences on trauma, addiction, and mental health. She is also an adjunct professor at Westchester University and Philadelphia College of Osteopathic Medicine, and is the vice chair of the Delaware County Drug and Alcohol Planning Council. Our next presenter, Cara Falco, is the associate director of the Heartwood program. Cara has joined Healthy Foundations Group as a psychotherapist with a specialization in substance use disorders. She was awarded the University of Maryland School of Social Work Exemplary Clinical Student of the Year for 2021. As a Substance Use Disorder Interventions Fellowship at the University of Maryland, Cara engaged in training to better serve and aid clients that are experiencing difficulty with alcohol use, drug use, and other addictive behaviors. Cara is open to working with clients with a variety of concerns such as substance use disorder, comorbidity, substance misuse challenges, depression, anxiety, and challenges with mood. She believes in the importance of understanding the client in their environment and takes a holistic approach towards helping someone on their wellness journey. Cara is motivated to put this perspective and her training in motion with the Healthy Foundations Group. Our third presenter today is Brianna Hurwitz, substance use disorder specialist at the Healthy Foundations Group. Brianna received her master's degree from the University of Maryland in clinical behavioral health social work with a focus in substance use disorders. While studying at the University of Maryland, Brianna gained specialized experience as an engaged fellow in the Substance Use Disorder Intervention Fellowship. Before joining Healthy Foundations Group, Brianna was the case manager at a treatment facility in Maryland where she worked with clients who struggled with addiction in outpatient, intensive outpatient, and partial hospitalization levels of care. Brianna is very passionate about helping those who struggle with substance use and co-occurring disorders. She believes the therapeutic alliance is the most important dynamic. Brianna uses a strengths-based approach in combination with motivational interviewing to promote self-empowerment. Thank you to all three of our presenters today, and I'm now going to hand over the presentation to Brianna, who's going to get us started. Thank you guys again for your time today, and thank you all for joining us.
Thank you so much, Jess. I'm happy to be here and to participate in this with Cara, Dr. King, and all who have joined us. I'm sure most attending today are familiar with ACEs. I'm going to provide a brief overview of ACEs and the original Kaiser CDC study. The original Kaiser study was one of the largest studies researching the impacts of neglect, abuse, and household challenges on a child's well-being later in life. The research took place from 1995 to 1997 in California, in Southern California. The study showed reports of one or more ACEs had a strong correlation to negative outcomes over the course of a child's life. Adverse childhood experiences have now been divided into 7 categories you'll see on the slide: psychological, physical, sexual abuse, witnessing violence towards mother, living with household members who were or are substance users and abusers, mentally ill, suicidal, or have ever been imprisoned. Next slide, please. The CDC further defines each of these ACE definitions. Resources are listed at the bottom of the slide, you'll see there, and provided to you at the end. I'll briefly say that abuse is categorized into emotional, physical, and sexual. Next slide, please. And you'll notice with mothers treated violently, a mother does not need to be the biological mother. The CDC says that it can be a mother, a stepmother, or a mother figure. You'll also notice with household challenges, there's a common theme of instability, where there's inconsistent and possibly sudden rupture of change in the environment. Next slide, please. Neglect is categorized into 2 components: emotional and physical. This differs from emotional abuse and physical abuse. The CDC says that is the failure to meet a child's basic physical and emotional needs. These needs include housing, food, clothing, education, access to medical care, and having feelings validated and appropriately responded to. With neglect, there's an extreme lack of emotional support and an extreme lack of physical safety or care. Next slide, please.
And the ACEs study was the start of a fundamental shift in our understanding of how adverse childhood experiences impact somebody emotionally and physically over the long haul. While it was a fabulous study and it really helped us understand these things, there are several other commonly experienced adverse childhood experiences that were not captured in the ACEs study. So I wanted to take a moment and highlight a few of them now. So one of them is extreme poverty. So this can lead to significant inconsistencies in the home, in the school environment, or in the community, as well as depriving a child of some basic needs or material goods. Another one is experiencing racism or discrimination, and this could be where an individual is the direct target of that, or if they're witnessing that. Exposure to community violence is another area. And so this can contribute to a lack of safety in an environment, but it can also deprive a person of having healthy, adaptive experiences within their community. Another one is severe peer bullying or maltreatment. So bullying can range from physical aggression or extreme gossiping or exclusion. And so these are believed to also have similar impacts on an individual as what we see with the ACEs. And now I believe that most of you are probably familiar with the DSM. And so as we're going through the ACEs, you've probably noticed that most of the ACEs will meet criterion A of the DSM to meet criteria for a diagnosis of PTSD, but not all will meet that criterion. So criterion A requires death, threatened death, or threatened or actual serious bodily injury, or sexual violence. So not all will meet that criteria, but still can have significantly lasting impacts, just like the other ACEs that meet that criteria. So you might see people that meet criteria for an other or an unspecified trauma and stressor related disorder. So we'll discuss how these experiences have lasting impacts on an individual, especially when they occur early in life, when they're severe ACEs, and also the accumulation of ACEs over time. Next slide, please. One of the areas that we're going to talk about is the impact ACEs have on the developing brain and body. So traumatic experiences cause both an immediate and a long-term effect on both the brain and body. And there's been significant advances in brain imaging technology that allows researchers and clinicians to have a very nuanced understanding of brain development, as well as the impacts of trauma on the brain. And so you don't necessarily need a very in-depth understanding of brain anatomy, but it is helpful to know a general understanding of how trauma affects the brain, because it will give you a more compassionate understanding of when somebody's trauma is triggered. It also helps to make sense of why some of the bottom-up approaches to treating trauma are so important. So when something happens that overwhelms our capacity to cope, that's mediated by the limbic system. And so the limbic system is a more primitive part of the brain, and its goal is survival. So the amygdala gets activated when something really stressful in our environment happens. And the amygdala is responsible for detecting threat. It's also responsible for starting that fear reaction. And so what happens is the frontal lobe will decrease its functioning. We'll also have the sympathetic nervous system kick in, the HPA axis get activated, and those are the systems that are responsible for the release of epinephrine, norepinephrine, cortisol, and adrenaline. And so that really sets that body into survival mode. So that's that fight or flight or freeze response. And so in a healthy response to a traumatic situation, we would see a rise in the cortisol levels followed by a rapid decline in cortisol. So this is sometimes referred to as the trauma-induced feedback loop, because the release of cortisol itself actually triggers the body to stop releasing cortisol. And it triggers the discontinuation so the body can go back to its own homeostasis and try to recover from that incident. Another way that traumatic experiences impact the brain and body is that memories that overwhelm our capacity to cope are stored differently than more neutral memories. So these memories are stored in the amygdala, and the amygdala stores them there because it wants the brain to remember anything that's similar to that event so it can protect the body. And so that is in part why we see some of that re-experiencing symptoms that we see in trauma disorders. With it being stored in the amygdala, it also prevents the person from being able to use that information from the traumatic experience to help guide them in future decisions and future actions, because it's not a fully processed memory. And so without the ability to use that memory to help them guide future action, it can cause the person to develop experiences related to shame, and it can also cause some negative perceptions from other people, because other people might not have an understanding about why a person can't learn from past traumatic experiences. Next slide, please. Okay, So when we look at trauma disorders, when future reminders of traumatic material are present in a person's environment, the same sequence of events happens that we just talked about on the last slide. So the amygdala gets activated, the sympathetic nervous system and the HPA axis all get activated. And so there's that cascade of hormones released to try to protect the person. And the prefrontal lobe decreases its activation. And the prefrontal lobe is the part that's responsible for a person's higher level functioning, higher level thinking. So their ability to critically think about a situation to determine whether it's safe or not. So that part gets offline, and it's really that more primitive part of the brain that is in control to try to really help the person survive. And what we see in research is that this prolonged activation can cause damage in the neurons in the hippocampus. It can depress the immune system, and it can also contribute to that physiological hyperarousal that we see in trauma disorders. An interesting thing that we see in research is that people who have faced great adversity or traumas, especially in childhood, have lower levels of cortisol. So that trauma-induced feedback loop that I talked about in the last slide isn't functioning properly. And so what happens is the trauma-induced feedback loop isn't able to stop the body's stress response, and that results in high levels of adrenaline. So it can cause a disproportionate reaction for a longer period of time. And I think it's also important at this point to point out some of the research that we're finding related to epigenetics. And epigenetics is just the study of how our behaviors and our environment can contribute to gene expression. And Dr. Yehuda out of Mount Sinai is doing a lot of research on cortisol and epigenetics. And what she's finding in her research is that experiencing traumatic events can cause changes in DNA regions that are linked with cortisol receptors, which potentially make them more sensitive, meaning that it takes less of the cortisol to be released to cause a disproportionate physiological reaction. And something that's really fascinating is that we're seeing that these epigenetic changes in the DNA regions can be inherited from parents. And so parents that have experienced traumatic events and developed PTSD, even prior to conception, can pass these DNA changes onto their offspring. So it was first discovered in the offspring of the Holocaust survivors. And it has given the field a lot of good information about the intergenerational transmission of trauma and trauma disorders. And so if that's the case, it sets the child up to have a higher likelihood of going on to develop PTSD or other mental health conditions. And then when we look at just the brain volume in general, chronically maltreated children, whether that's abuse or neglect, have decreased brain volume, specifically in the hippocampus, the frontal lobe, and the corpus callosum, as well as the cerebellum. So among other things, this causes a diminished ability to cope, difficulty regulating emotions, difficulty understanding oneself, and difficulty connecting with others. Next slide, please. Another area that I want to draw your attention to is the psychosocial development. So if you've ever taken an intro to psychology course, you should be familiar with Erik Erikson's stages of psychosocial development. And so I bring this to your attention because I don't want us to only focus on, in regard to the ACEs, what's happened to the child, but I also want you to think about what was missing or absent from a child's life as a result of the ACEs. So most children are very resilient as long as their basic needs are being met and they're in a safe and stable environment. And what happens with ACEs is that having ACEs in someone's childhood can severely disrupt that. So for instance, if a child in the first year of their life, if their parents are abusing substances, and say maybe there's some neglect or abuse in the home, that can really interfere with their ability to develop a sense of trust and safety in the world. And so as a result, they might experience significant mistrust and suspicion and have this tendency to withdraw from the world or from other people. And what we see is that if somebody isn't able to successfully complete or successfully resolve one stage of psychosocial development, it impacts their ability to successfully move through the other stages. So the earlier that the person experiences an ACE or multiple ACEs, the more global the impact can be for that individual. Next slide, please.
Okay, so now that we've talked about some of the general ACEs outcomes, we're going to start to connect the relationship between adverse childhood experiences and substance use disorder outcomes. So first, the original ACEs study showed that, excuse me, 4 or more adverse childhood experiences from any category can increase a person's health risks and have a significant impact on their quality of life over time, as Dr. King discussed. Today, since we're focusing on that correlation between trauma and substance use disorder outcomes, it's so important to note that having 4 or more adverse childhood experiences puts a person in a place where they are 4 to 12 times more likely to develop a substance use disorder. Just as a quick note, a person having just 2 or more ACEs can increase the likelihood that that person will smoke at some point in their life and have self-reports, again, anywhere from childhood through adulthood of experiencing poor health. And now I want to highlight that I mentioned that people with 4 or more adverse childhood experiences are anywhere from 4 to 12 times more likely to develop a substance use disorder. The statistic varies since people within specific demographics are more susceptible to these adverse health outcomes. I'll talk just a little bit more about that. If we're looking at additional factors outside of adverse childhood experiences, we could look to things like socioeconomic status that can influence and increase someone's susceptibility to, again, developing a chronic disease like substance use disorder. And so very briefly, we can look at gender, for example. Studies show that women have a higher likelihood of being at risk for developing something like SUD. And also when looking at race, we see Black people, people of color, they are also more susceptible, higher on the end of anywhere of 10 to 12 times more likely to develop a substance use disorder. And when we put gender and race together and we analyze the studies there, it's so important as practitioners that we do understand that Black women in particular can be more susceptible to developing a substance use disorder when they've experienced an adverse childhood experience or trauma in general. Next slide, please. Great. And Dr. King touched on some of this. I'm sure many of you are familiar with this pyramid, especially if you work in the trauma field. So this is a depiction of adverse childhood experiences and their impact over one's lifespan, if you're not familiar. So I do want to note that experiencing just 1 or more childhood experience has been known to set a person out on this trajectory demonstrated here in the pyramid. Towards the bottom of the pyramid, you'll see the adverse childhood experiences. Once a person experiences an adverse event in childhood, we do begin to see disrupted neurodevelopment, as Dr. King talked on in great detail. And this can lead, again, to a trajectory where we're looking at social, emotional, and cognitive impairments for a person. This, in turn, can lead to the adoption of risky behavior. You're seeing that towards the top of the pyramid here. And the more frequently that one is engaging in risk-taking behavior or finding difficulty with impulse control, especially when they are engaging in substance use or abuse, what ends up happening is they are more susceptible and increasing their likelihood of developing a chronic illness such as substance use disorder. And once one develops a substance use disorder, especially if the condition is severe, which we'll talk more about later, it's so important to know that, of course, we know that there's correlation to early death. Next slide, please.
So now that we've reviewed adverse childhood experiences and outcomes, particularly substance use disorder outcomes, I'd like to transition. I'm going to briefly discuss substance use disorder criteria, levels of severity of substance use disorders, and briefly touch on ASAM levels. And here are the DSM-5 criteria, which I'm sure you're all familiar with. Just a reminder for practitioners to use a diagnostic manual to help identify the presence of a substance use disorder in a client. Next slide, please. The DSM also categorizes substance use disorder into mild, moderate, and severe based on substance use over the past 12 months. It's important to know of the 11 criteria, 6 or more symptoms indicate a substance use disorder. Next slide, please. In just a moment, Dr. King will be discussing in more detail the relationship between substance use, trauma, and treatment options with those who have a substance use disorder and have experienced trauma. While this is relevant, I'm specifically highlighting the national standard criteria and subsequent treatment that's recommended for a person with a substance use disorder. The American Society of Addiction and Medicine, or ASAM, created a set of guidelines in the 1980s to establish criteria nationwide in addiction treatment. Still used today, this criteria determines a client's appropriate fit for level of care with addiction and co-occurring disorders. You'll see 4 risk and 6 dimensions are considered in ASAM risk rating crosswalk. While discussing the specific crosswalk criteria is outside the scope of this webinar, please note that as a provider, you can rely on the ASAM criteria to help guide your recommendation for treatment if your client is experiencing a substance use disorder. Next slide, please.
And so we'll talk a little bit about the overlap here. And so when somebody experiences trauma symptoms, they're very unpleasant. So there's lots of physiological arousal. Because of that, people tend to try to avoid reminders of the triggers of the trauma. And so oftentimes people will turn to substances to try to quell some of that arousal and to also help them with some of the avoidance. And what we see is that as someone's substance use increases, their exposure to additional traumatic experiences also increase. So for example, somebody might be involved in a DUI car accident. They might witness additional traumatic violence. They might even become victims of physical or sexual violence in the pursuit of their substances or while under the influence. And typically, as traumatic experiences increase, so do the symptoms of trauma. And so what we see is that snowball effect. So as the symptoms increase, so does the substance use and so on.
Something else I want to mention here is we're marrying the idea that there really is a correlation between trauma and substance abuse and substance use disorder outcomes, is discussing how adverse childhood experiences, specific adverse childhood experiences, can correlate to specific substance use disorders later in life. And so I'll talk about that a little more here. For example, if one has witnessed abuse in the home, specifically witnessing violence towards their mother or a mother figure, or if this person has experienced living in the home with a parent who has an alcohol use disorder specifically, they are more susceptible to developing an alcohol use disorder or tobacco use disorder. Just something notable there. Also of very important notable information here. Experiencing physical or sexual abuse as a child can be associated specifically with opioid use disorder and polysubstance use disorders. Next slide, please. Okay, and so we've talked about the correlation between substance use disorders and trauma, and now we want to get into how you can consider screening for this. And next, we'll talk about implementing treatment approaches. So one of the things that we want to talk about first, before we go into any specific screening tools, I want to emphasize the importance of screening for both adverse childhood experiences and the presence of substance use or substance use disorder when a client is presenting with either trauma or substance abuse. Because we know of the correlation between the two, it can be very important to screen for both at intake in particular. So with the correlation between trauma and substance use disorders, whether you're in private practice, at a substance use disorder agency, or elsewhere, engaging this client up front at intake to understand where the client is at, and not only just in intake, but over time, periodically, either every several weeks or every couple of months to assess will be important. And so, of course, each agency needs to design their own way of screening and assessing for things like adverse childhood experiences or substance abuse. However, I'm really hitting home here that prioritizing these screens can inform practice and really help clients to receive the most appropriate level of treatment. And so here with the ACE screening tools, I'll just briefly touch on some of the options that have come from some of the studies that we've sourced and some of the resources that we use ourselves. So the 10-question ACEs screening tool is standard. Again, it is conducted at intake when meeting with a new client, because we do understand that there are some constraints at certain agencies, maybe staffing or time constraints. There are other options that you can look out for. A 3-question ACEs screening tool, for example, is more effective than not asking about adverse childhood experiences at all. And let's say if you have more time, more ability to do a comprehensive screen, perhaps the client is presenting with trauma, you want to learn more, we just want to let you know that there are ACEs screening tools that have more comprehensive questions, 11 to 13 questions, for example. And now other tools, just to put it on your radar to assess and screen for trauma, include PACEs, the CTQ, and the Childhood Sexual Abuse Questionnaire. Next slide, please. Okay, now we'll dive into assessing for substance abuse or substance use disorder screening tools. First and foremost, you'll see the top bullet point here is SBIRT screening. So SBIRT screening, which is where you are screening a client using one of the screening tools that are listed below, engaging the client in a brief intervention and referring them to the appropriate level of care. This is the standard, if you will, for screening for substance use, especially if a client is presenting with substance abuse challenges and you suspect a potential for a substance use disorder. And so very quickly here, you'll see the CRAFT, the 2.1 version specifically, they've recently updated. The CRAFT is designed for clients 12 to 18 years old. Yes, this is very important. Even as young as 12 years old, you can be screening for the presence of a substance use disorder. And so you would use that as the one of the most effective and appropriate tools for a teenager in particular. And the Audit C is for clients who are 18 years or older, specifically to assess for the presence of alcohol abuse or alcohol use disorder. And the DAST 10, that is for any screening for drug use, whether it be over the counter or illicit drugs, for clients 18 and older again. And so I just very briefly want to talk a little bit more about this SBIRT screening. Once you have engaged a client in the screen, we do know that motivational interviewing is a good follow-up. If you suspect and you see, using the scoring criteria for each of these screening tools, that there is a high risk for developing a substance use disorder, or perhaps there's a presence of a substance use disorder. Again, motivational interviewing is a good technique to engage the client to see where they're at, see if you can help the client to raise their insight, assess their capability and their desire to make a change, if any, and then from there, referring to the appropriate level of treatment. Perhaps if you're an outpatient, they need a higher level of care, or perhaps you can assess if they are in the appropriate level of care, where they are with beginning their work with you. And so something that I do also want to mention is that we completely understand here too, that not every agency has the capability of doing an SBIRT screen at every intake. From my experience, it can take up to 30 minutes or sometimes longer. And so again, this is something that we're emphasizing the importance of simply screening. Even using just one of the screening tools below can increase the likelihood that you are properly informing your practice in the treatment plan for the client and getting them, most importantly, in the right level of care for them. Next slide.
And historically, it was believed that trauma and substance use disorders needed to be treated separately. So if somebody was struggling with both and they presented to a trauma professional, they might have been told that they had to get into recovery before that they can address the trauma. And vice versa, if they presented to a substance use professional, they might say that they had to work on the trauma before they could start working on recovery. And so what we know now is that the most effective way to help somebody that's struggling with both is to simultaneously address both issues. So as Caron mentioned, screening for both of them is the first step of that. What we also recommend is trying to implement some trauma-informed practices at an organization or even in your own individual practice. So the CDC, in collaboration with SAMHSA, developed 6 guiding principles to help organizations adopt more trauma-informed approach. So the 6 are listed here. So safety, so that references a person's physical and psychological safety. Trustworthiness and transparency. So this is with staff, with patients, and any family member or individuals involved in the person's care. Peer support, so that we can help individuals build healthy and supportive relationships. Collaboration and mutuality. This really references that everyone has a role to play in trauma-informed care. Empowerment and choice. So this is really building upon an individual's strength, helping them to see the choices that they have in a matter, especially because when somebody's experienced ACEs or other traumatic events, they often didn't have a choice in the matter. So choice is really important in a trauma-informed approach. And then cultural, historical, and gender issues. So to come from a trauma-informed perspective, organizations really need to address and work to resolve some of the stereotypes and biases that might be inherent in their organization or in their practices. Next slide, please. Okay. And so when we think about trauma treatment specifically, it's recommended that there be a phase-based approach to treating trauma. And there's generally 3 phases. So the phases are listed here. So phase 1 is safety and stabilization. So this is really helping an individual develop their own personal sense of safety, helping them develop a standard for self-care, tapping into some internal resources, helping them figure out how to manage unpleasant and intense emotions. And so as we discussed, if an individual experienced significant ACEs earlier in life, they might have more global impairments. And so they might need a longer time or a more extended period of safety and stabilization before progressing into the phase 2, which is the remembering and grieving. And this stage is typically what people think of when they think of trauma treatment. So this is where the individual is going to reprocess the traumatic memories to resolution, usually using trauma-informed approaches such as EMDR or CPT. The final phase is phase 3, reconnecting and integration. This is where a lot of post-traumatic growth can occur. So this is where the individual is building upon all of those newly found positive and adaptive beliefs that they have about themselves and the world, and hopefully establishing safe and healthy connections. And it's important to note that the progression through all of these phases is highly individualized. And so as you're doing trauma treatment with an individual, you are responsible for really assessing to make sure that a person has a sense of safety and stability, and ensuring that they're ready for that next phase of treatment. Next slide, please.
So there are 2 approaches that correspond with the 3 phases of trauma treatment Dr. King just spoke about: top-down and bottom-up. A bottom-up approach explores how one's environment influences one's thinking, and the focus is on sensory analysis. You'll see when a bottom-up approach is utilized that you're honing in on processing clients' raw emotions and sensory experiences. Techniques such as yoga and EMDR can be really helpful when using this approach. And a top-down approach analyzes how one's thinking influences how one understands and perceives the environment. The focus is on a cognitive process, and a top-down approach emphasizes helping the client shift the way that they think. Examples of top-down techniques could be CBT and CPT. And now I'll turn it over to Dr. King to discuss the approaches to bottom up processing in more detail.
Next slide, please. Thank you. So as Brianna mentioned, bottom-up approaches really try to work on that more primitive part of the brain, which we talked about is overactive in trauma disorders. And so there's really no general consensus of how much bottom-up versus top-down approaches should be involved in a person's trauma treatment. What's most likely is that there should be a combination of both. So we know from what we talked about earlier that that more primitive part of the brain is overactive in a trauma disorder. And there's also a disconnect between the higher level of the brain, such as the frontal lobe. And so what we want to do in trauma treatment is to try to quell some of that overactivation and also forge that reconnection to that frontal lobe. And we can do that because of brain plasticity. So brain plasticity is really the brain's ability to learn and adapt based off of repetitive new information. So a lot of the bottom-up approaches are going to require a lot of repetition. And what we're seeing in research is that mindfulness-based stress reduction, trauma-sensitive yoga, and expressive art therapy are really good adjunctive trauma treatments to help quell some of that overactivation in the limbic system. And so I said adjunctive because it doesn't necessarily help forge that connection. And that's where we have to have that more integrative approach. EMDR is another treatment modality that can help somebody through the full phases of trauma treatment. So this is a modality that addresses the traumatic memories where it's stored in the amygdala and helps a person work to a healthy and adaptive resolution of the traumatic memories. And sometimes what we see is that people have so much dysregulation, or they're experiencing such severe anxiety or depression that their processing is being blocked because of the severity of that dysregulation. And so sometimes psychotropic medication is necessary to help bring a better balance so a person can work through the treatment. And what we also see is that as somebody is trying to approach treatment with both substance use and a trauma disorder, they might be having a lot of urges and cravings to use. And so that the urges and cravings could be very distracting to their ability to progress through treatment. So medication-assisted treatments is sometimes also necessary in order to help them work through treatment. Next slide, please.
And so now taking a look at the top-down approaches. So as Brianna mentioned, top-down approaches address cognitive processes. Interventions are behavioral in nature. Top-down approaches can be appropriate when a client's behaviors in the here and now are negatively impacting their life, perhaps maybe even putting their life at risk, and a need for skillful behavior and to stabilize is necessary. It's imminent. And again, given what Dr. King said, it would be contingent on their ability to process and to be in a space where they could enact some of these more behavioral approaches. And so here is a list of some of the evidence-based approaches that can help specifically with substance use disorder treatment and also with substance use disorder treatment when it is presenting comorbid with trauma. And so one of the first things, as I mentioned a bit earlier, is motivational interviewing. This is an approach that can be used in conjunction with other approaches that are listed here. For example, cognitive behavioral therapy, dialectical behavioral therapy, and cognitive processing therapy. Again, incorporating motivational interviewing to help the client increase their insight, perhaps increase their motivation to make a change where change may be needed and they want to make a change, and also to help them to feel more capable of doing something different in their lives. And these other treatment modalities here, again, CBT, contingency management, DBT, and CPT can all be used in integration with tailored care for the client to help them to increase their skillful behavior and stabilize. To Dr. King's point again, to find safety and stabilization in some of the skillful behaviors that they are learning. Next slide, please.
And so we hope that from this presentation, you can see the importance of screening for both ACEs and substance use disorders when you're working with patients that present with either trauma, substance use, or both. We also hope that we have covered that it's clear that there's many different evidence-based practices that can help an individual with trauma disorders as well as substance use disorders. And there are things that you can implement in your standard practice to make your practice a more trauma-informed practice. And so when we think about prognosis is very highly individualized. And so it really depends on a number of factors, but what we find is that many people that are engaged in evidence-based practices will fully recover from both substance use disorders and trauma disorders. And so without treating both of them, the person is susceptible to relapsing in either the substance use or a trauma disorder. And so next slide, please. Okay, that is our references, and we want to thank everyone so much again for being with us. And I think we'll have some time for some questions.
Thank you guys so much. You wrapped up right at 12:50. That was perfect. We did have a couple questions that came in. I want to ask the first one we had, are those medications that you had mentioned, Dr. King, used only during the treatment process? I think it was a couple slides back, you talked about medication.
Yeah, so sometimes people are going to need medication for a long period of time, but with effective evidence-based treatments, people can fully resolve their PTSD and not need additional medications in the future. So it could be a time-limited approach where there's a combination of psychotropic medications and therapy. So it is something that the ultimate goal is to resolve the disorder and resolve the symptoms so that person can have that adaptive processing of the traumatic experience so they don't need medication in the future.
Wonderful, thank you. I'm going to ask first a couple of the questions that came through during the registration process, and then we'll try to get to the live questions. If for some reason we don't get all of your questions answered, we will have the presenter answer the questions, and then the RRD for your region will follow up with the answers to those questions in an email. So the first question that we have come through is, how do we help clients recognize the impact of ACEs without having new resentments?
Sure, great question. So I'll go ahead and jump in and start with this one. So to answer this question, in our talk today, we've identified how a psychotherapeutic approach to identifying and treating trauma and substance use disorders is evidence-based, and it's something that we, in discussion today, can elaborate and say that particularly with psychodynamics, we find that actually helping a client to name what they've experienced and process any resentments or other emotions that come up is a part of the healing process. So as Dr. King discussed with the phases of trauma treatment, one of the first things that you want to do as a clinician is establish safety and stability. And it's a first step that is so important. Even as early as intake, you can be creating that safe and stable place as you're building rapport. You can validate for the client if they've experienced an adverse childhood experience that it was not normal. It's okay to be upset, and let's talk about that together. And again, it really can help a client to build that trust and rapport. We wouldn't, psychodynamically speaking, we wouldn't want to shield a client from any resentments that do come up because they're being held on the inside, and we want them to come up so that they can process and heal.
And
Awesome.
I just wanted to add briefly to that is that the goal of the trauma treatment is to have an adaptive and healthy interpretation of what happened. And part of that healthy and adaptive interpretation might include the understanding that maybe mom and dad were sick, or mom and dad did the best that they could with what they had. And so it still honors that there was something that happened that shouldn't have in childhood. And it is a much more compassionate and empathetic approach to the parents. And so like Cara mentioned, to get to that end result, there might be some resentment, there might be some anger that comes up, but effectively working through that is the ultimate goal of trauma treatment.
Great, thank you both very much. Another question that we had, are there differences in the treatment approach based on cultural differences and diversity?
Sure, I'll go ahead and start to answer that too. And if Brianna or Dr. King, you'd like to jump in after, please do. Another great question. So I think, yes, there are things to consider. One of the things is that, for example, I talked a bit about a top-down approach and how you're doing cognitive processing at that stage of treatment or in that moment. And I think it's so important to say that, for example, with people of color, if someone is experiencing systemic racism, that is not a cognitive distortion. That is something that is real, it is valid, and it's our responsibility to hold the space for that reality for the client. And so just briefly, one of the ways to most effectively intervene is to validate and to say, yes, this happened. We don't need to correct that. It's not a delusion. It's not a distortion. It is a reality for some people. And it's very important to use that as a therapeutic tool, that validation and that holding the space of their reality.
Wonderful. Another question that we have, how do you recognize the contribution of ACEs with the evidence of genetic factors in substance use disorders? Any takers?
I was going to say, Dr. King, you want to take that one?
So I think as we mentioned, the The genetic changes can be inherited from parents. The genetic changes in the brain can be inherited from the parents. And then if they don't have those inherited epigenetic changes, they can then develop them as they experience adverse childhood experiences or other traumatic experiences. And what happens is the brain becomes so dysregulated, the normal functioning is not able to help the brain go back to its own homeostasis. And so our goal is always, the limbic system's goal is always to try to survive. And it can be really exhausting to have that activation. And so what happens is people tend to turn to substances to try to quell some of that. And as somebody turns to substances, they might also have a genetic predisposition to addiction, and their substance use takes off. And some people, it's that snowball effect that we talked about earlier, is that it just is a slow progression based off of the intertwining nature of trauma and their substance use to cope with it.
Thank you. So another one that we have that I think is a really interesting question: are cultural events like the COVID pandemic and repeated mass school shootings considered ACE events for everyone living in the US in the past decade?
Yeah, go ahead, Dr. King, please.
So I was going to say that's a fabulous question. And I think that, like I mentioned in the beginning, the ACEs study was absolutely transformational, and it didn't include everything. So I think that as we are starting to build our understanding of how these adverse experiences impact us, we're seeing that there's other things out there that are commonly occurring. So I would absolutely include that mass shootings and the pandemic. I would include those in adverse childhood experiences. So they might not be like captured in the ACE screeners or specifically in the ACEs study, but I would suspect that they are going to have very similar experiences and consequences as the original ACEs.
Okay, and last question. The polysubstance abuse disorder diagnosis being removed from the DSM-5 criteria has left this writer unclear about how to best categorize people who dabble but don't regularly abuse any one substance. Think the person who uses whatever they can get their hands on. What diagnosis or diagnoses do you generally give them?
Great question. I'm thinking about what I do in personal practice, and please, Dr. King and Brianna, jump in. For me, if there's a prominent substance, I think this dials back to what Brianna spoke about with taking a look at the DSM criteria, level of severity, also screening tools, right? If there's any risk, let's say it's the primary substance of choice, maybe alcohol, I might put alcohol abuse. I believe there's an F code for that. I understand polysubstance use disorder is no longer in the DSM. If someone has maybe perhaps a mild alcohol use disorder and dabbles with other substances, I might put alcohol use disorder mild and determine specifically where we're looking. At least in my EMR, there is an F code for polysubstance abuse and not the full disorder. So that's what I do. And I continue to screen, quite honestly, too, to see if anything's changed in the level of severity.
Wonderful. Thank you guys so much. Dr. King, Cara, Brianna, you guys did a fabulous presentation. We're getting great feedback in the chat. Everyone's very appreciative. So thank you. And thank you to all of our attendees who have joined us today. As a reminder, this presentation is available for 1 continuing education credit as long as you were on for the full hour or at least 50 minutes. Keep an eye out on your email. You're going to receive an email right after the presentation from cego.com. They're the ones that send you the evaluation. Complete that evaluation and then you'll be able to print your certificate. And a couple of new things. Caron has some exciting things coming up. On July 24th, we are kicking off our Countdown to Kiel webinar series that will walk you through Caron's new 100,000 square foot state-of-the-art medical center that will be opening in January 2023 in Florida. Our first webinar starts with Dr. Phoenix Adams discussing the motivation behind opening the Kiel Center, what it means to the treatment industry, and how we meet the needs of our patients, their families, and the community. Further out, on November 4th, Caron is hosting our 7th annual Addiction Research Symposium. Registration is now open and you can take advantage of early bird pricing. This event has been approved for AMA PRA Category 1 credits. Please visit us at caron.org/webinars for more information and to register. Check your email for more details. And in the meantime, reach out to your local regional resource director at any time for additional information for resources in your area or questions regarding admission to any of Caron's programs. I want to thank you all again for joining us. Have a great rest of your day. We'll see you next time. Thank you guys so much.